Two, one. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on Browse Breast Oncology with Scientific Experts HER2. And with immense pleasure, I would like to invite Dr. Chirag Desai, who is Consultant Medical Oncologist, Director, Hemato-Oncology Clinic, HOC Vedanta, Ahmedabad, for the welcome and introductory note and to take the proceeding further. Over to you, sir.
So thank you very much and good evening, everyone. It's my pleasure to participate in this wonderful scientific meeting where we are going to discuss about the nuances in breast oncology, particularly with reference to HER2 positive early as well as metastatic breast cancer. So we know that immunotherapy is making an inroad of late in oncology. If you look at the survival curves of any oncology trial, we look at early iteration of large number of patients, and then at the tail end there are number of patients who are surviving for a very long time. So if we didn't select our breast cancer patient for HER2 positivity and treated all comers with anti-HER2 therapy which are available today, I think the curve would have been same. The reason is for immunotherapy, we don't have a robust biomarker. Well, thankfully, we have a wonderful biomarker for breast cancer. Of course, we have hormone receptor, but we also have HER2, which is a powerful biomarker. The most exciting discovery in any area of oncology has been in the area of HER2 positive breast cancer in last maybe decade or so. And we have a large number of drugs already approved and a large number of drug under development for this segment. Everything I said was pertaining to HER2 positive breast cancer. It means that HER2 positivity, the report has to be given by the pathologist. So pathology report makes a very important contribution to the success of our treatment of breast cancer, particularly in HER2 positive breast cancer. And when we have new entities like HER2 low and HER2 ultra low coming in, it becomes very important for all of us clinicians to have a wonderful interaction and a rapport with our pathologists. So with that context, I invite Dr. Kunal Sharma, who is the Associate Director and Head of the Department of Center of Excellence of Histopathology. And he is with Global Reference Laboratory, Agilus Diagnostics in Mumbai. And he will be speaking about evolving paradigms of HER2 testing in breast cancer. Dr. Kunal, please.
Thank you, Chirag sir, for setting the tone so well. Am I audible to all?
Yes, yes.
All right. So I think I can't switch on my video, but I'll try and share the screen directly. 1 second. Entire screen. I'm not able to share my screen. So you'll have to make me a co-host.
Sir, please try again.
Okay. 1 second. Yeah. Now I'm able to do it. 1 second. Is my screen visible?
Yes, sir.
Yes, sir, it is.
All right. So I'll start with my session. So I will mainly be talking upon the evolving paradigm of HER2 testing in breast cancer. We all know that HER2 has really changed, how we looked at cancers as being one of the first biomarker and a very effective one at that, with the, especially with the utility in breast cancers, and how anti-HER2 drugs have changed, the survival rates in patients who show amplification of HER2. So I would just like to, talk a little in the beginning about breast cancer. We all know that it is the commonest cancer in women globally. It has outdone lung cancer as the most common cancer worldwide. As per the Globocan data, which was released in 2020, it constituted 24.5% of new cancer cases in women and about 11.7% of new cancer cases overall. It has shown an increased prevalence even in Asian countries, including the Indian subcontinent. In India, breast cancer has long replaced cervical cancer as the leading cause of cancer and cancer related deaths in women. Uh, the etiology is multifactorial. It's genetics, it's diet, it's reproductive factors, hormonal imbalances. Inherited gene mutations like BRCA1, BRCA2, PALB2, they greatly increase the risk of breast cancer and they show high penetrance. About 50% of breast cancer cases occur in women with no prior identifiable cause, and up to 85%, especially in US, without a family history. Breast cancer today is a molecular disease. We do not go by a one size fits all approach, and we know that individual risk of recurrences, genetic signatures can all be different even when morphology is same. Hence, each patient who is diagnosed with breast cancer needs to be evaluated individually for prognostic and predictive biomarkers. Thus, the role of a pathologist has, it is a cornerstone to give the right report to your oncologist so that he knows exactly what kind of treatment a particular patient needs. The risk factors are could they range from an increased age to age at first live birth, nulliparous women, late pregnancy, that causes more of proliferation of cells with preneoplastic changes, high calorie rich diet, first degree relatives with breast cancer, non-Hispanic whites show a much higher incidence. Also, high breast density because of less complete involution of lobules at the end of each menstrual cycle, radiation exposure, cancer of contralateral breast or endometrium, a part of the hereditary cancer syndrome, exogenous hormones. There are geographical differences with incidences being higher in US and Europe. In India, we know that we usually see more of triple negative breast cancers who present earlier. Alcohol consumption, lack of exercise, obesity, smoking are all associated with increased risk. This is just to give you a more recent data which came from US, that about 15% of all new cancer cases in US were breast cancers. 7.1% of all cancer deaths were from breast cancer. And if you see the 5-year relative survival, it was 90.6%. What this goes to show you is that if you pick this disease early and if you treat it correctly, there are chances that the patient will survive more often than not. This is another statistical representation of percentage of cases by stage and their relative survival. You see, when the disease is localized, the survival is extremely high, almost 99%. But when the disease has distant metastasis, it falls down to about 30%. So breast cancer progression earlier was thought to be due to usual ductal hyperplasia going into flat epithelial atypia, but that is no longer encouraged because UDH is now considered to be a separate spectrum of pathology. Now we know that it is flat epithelial atypia that goes to ADH, atypical ductal hyperplasia, to DCIS, to invasive ductal carcinoma, and this is how breast cancer occurs. I would just like to tell you that based on the ER, PR, HER2, and KI that are the 4 things that we test in a case of breast cancer, there are different molecular subtypes: luminal A, luminal B, HER2 enriched, triple negative, normal like, and Claudin low subtype. Luminal A we know are ER and or PR positive, HER2 negative with low KI. They are treated with hormonal therapy. Luminal B are again ER and or PR positive, HER2 positive or negative, and high KI. They are relatively more worse prognosis than luminal A. HER2 enriched is the one that we are more interested in as pertaining to this talk. These are the ones which show HER2 positivity, and although they are more aggressive than the luminal counterparts, but they show very good treatment response to targeted therapies. Then we have triple negative, which are the worst. Normal like are almost like luminal A, but carry a relatively worse prognosis. And then we have the Claudin low subtype. Now, there are different ways in which HER2 can be assessed. There is immunohistochemistry, there is, dual color, dual in situ hybridization, and there is the fluorescent in situ hybridization, or FISH. We all know that usually when a breast cancer case comes to us through immunohistochemistry, we do our ER, PR, HER2, and Ki67. Now, uh, you know, whenever the HER2 is equivocal, that is, it stains 2 plus by immunohistochemistry, we have to do a reflex testing with in situ hybridization. In situ hybridization could be a fluorescent in situ hybridization, or it could be a chromogen dependent in situ hybridization, something that that forms the basis for dish. So there is a paucity of time. It's very difficult to explain a very vast topic in such a limited time. So I will just like to stick to the main points, which drive our message home. So basically, the idea is whenever we get HER2 equivocal, we tend to put it for reflex testing by FISH. This is just a progression of how HER2 in breast cancer has gone from 84, 85 when the gene identification took place to the 2018 when we have the current guidelines. Now, this is the algorithm for HER2 testing as per the 2018 ASCO-CAP guidelines. So, what is 3 plus on IHC is clearly positive. What is 2 plus is considered equivocal. On IHC, we used to traditionally call 1 plus and 0 as negative, but the current 2022 uh, ASCO-CAP has suggested that, I'll show you that slide first, that these 1 plus, 2 plus, and cases which are negative by ISH of metastatic breast cancer who have received at least one prior chemotherapy, we should consider these cases separately. That means that we should quantify whether our HER2 negative is 1 plus or 0, because 1 plus and HER2 2 plus, which are negative by in situ hybridization, would fall in a separate category that has shown phenomenal response by a drug called trastuzumab deruxtecan. Now, I'll just go back to the slides. So after this, you see that there is a category called HER2 low breast cancer. These are your IHC 1 plus, 2 plus by IHC but negative by FISH. And there is a drug called trastuzumab deruxtecan that has shown a very good response in these set of patients. Patients have lived nearly twice as long and lived 6 months longer overall, but they must have had at least one previous chemotherapy for metastatic breast cancer, and they would have had cancer return during or within 6 months of completing chemotherapy after surgery. This was the paper that was published in the New England Journal of Medicine. And the trial that was done was the Destiny Breast 04 trial. These were the exclusion criteria in sense that samples with less than 50% viable tumor cells, decalcified bone mets were excluded from testing, and samples were fixed in 10% neutral buffered formalin. And the HER2 4B5 clone was the one which was used for this trial. This is the algorithm which was followed in this trial, in which the IHC 0 was HER2 negative, ineligible for Destiny Breast 04 enrollment. IHC 1 plus, HER2, it fell in the category of HER2 low. These were eligible for the enrollment in the trial. IHC 2 plus, they underwent reflex testing, and if by in situ hybridization it was negative, again they were enrolled in the trial. But if it was positive, then that fell in the positive category or the IHC 3 plus category, which were ineligible for enrollment. So I will not go into the details of this, but what we saw was that NHER2 demonstrated a statistically significant PFS benefit. And, so basically what we showed was that even these patients with HER2 low, who previously were ineligible for a drug like trastuzumab, they finally had a drug like trastuzumab deruxtecan, which could be used. So the key points were that it was the 4B5 clone which was used for this trial, and that is the only clone which is approved for this category. And we saw that the results have the potential to improve treatment outcome in this category, which was earlier ineligible for targeted therapies. And if you see that this pool forms about 60% of our cases, 15% are HER2 positive, 85% HER2 negative, of which 60% are this category, which are now classified as HER2 low. Although HER2 low is a tag which CAP doesn't really want us to put, because we still are testing the 0 category of what is the level of amplification of protein expression, if any, and what is the treatment outcomes in those. But we should definitely quantify as a pathologist something which is 1 plus versus something which is 0. Because of the paucity of time, I will not be going into the details of different algorithms pertaining to FISH and the different groups which are there. I would just like to give you a brief comparison between FISH and between dual H, bright field dual H. Basically,
Sir,
what we
sorry for intervene. You need to conclude, please.
Okay, so all right, I'll just try and conclude it in a very short manner. The thing is that FISH is seen through fluorescent microscopy. FISH is something which requires a very dedicated setup, and also the archival as well as retesting of these slides is very difficult. Whereas when we go for a chromogen in situ hybridization, that is not the case, as they are done on your normal Ventana platform. It is very easy for archival of these slides. Also, they are not, the photo bleaching effect in fish is not seen in these slides. So basically what I wanted to tell you was that, so this is a slide which shows you negative uh, dish result, and this is a slide that shows you the black staining is the HER2 staining, and the other is the CEP17 staining, and then we calculate the ratio. So in short, what we have seen is that chromogenic ish is almost as good as fish, and especially in resource limited settings. There was this paper that was published from Tata Memorial Hospital in which they showed that dual ish is as good almost as fish, as it fits into the pathologist's regular workflow. There is faster turnaround time, okay, and it allows tissue architecture, morphology, and all the biomarker testings to be seen in the same setting. There is no interference from tissue autofluorescence, and as I told you, that results are very easily archivable. Just the final key message is that it showed high concordance with fish, 98.65%. Perfect inter-observer agreement was seen with kappa value of 0.98 to 1, and it is a very valid alternative to fish, and usefulness of D-dish in routine reflex testing is very much there. The not so far future is of deep learning and AI algorithms coming into HER2 testing. So just to summarize my talk, what we need to understand is that every test modality has a particular utility, whether IHC, dish, or fish, as defined by the ASCO-CAP guidelines. There is an ever-increasing importance of HER2 testing in personalized cancer care. HER2 dish is highly concordant with conventional fish and can be used as a reflex test. Dish bright field assay has a few added advantages in resource limited setting. I'm not saying that fish is not the gold standard. Fish is the gold standard, but dish has faster TAT, and it is much easier to do because it is on the same platform. And digital pathology solutions can further empower HER2 diagnostics in breast cancer. With that, I would like to conclude my talk. We have had a various amount of publications on HER2 testing. We also published a paper recently which was published in Springer Nature on HER2 gene in breast cancer. These are just some of the pictures from our various conferences and other things that we have done. And with that, this is my team at Center of Excellence in Mumbai. And with that, I would like to conclude my talk and thank the organizers, especially AstraZeneca, Roche, and Cancer Research and Statistic Foundations, for giving me this opportunity. Time was limited. I tried to, give a lucid description of whatever I could. Thank you.
So thank you very much, Dr. Kunal, for a wonderful discussion about introducing how you are testing HER2 and how do we interpret your reports of HER2. So now we have two panel discussion, and in between two panel discussion, we have a talk by Dr. Paolo Torrentino, who has joined already. Good morning, Dr. Paolo. And I will introduce you just before your talk. So before his talk, we have panel discussion, case-based panel discussion that is going to be moderated by Dr. B.K. Smruti, who does not need any introduction to this august audience. Dr. Smruti is a senior consultant medical oncologist at Bombay Hospital and Lilavati Hospital in Mumbai, who is very close to all of us in any of the academic endeavors. She is at the forefront. So I invite Dr. Smruti to start her panel discussion after inviting her panelists.
So, can you see my screen now?
Yes,
Yeah.
ma'am, we can see you.
Yeah, so I would like to invite Dr. Bharat Rangarajan, Dr. Krupa Shankar, then Dr. Vivek Sai, Dr. Ramvat Dev, Dr. Ashish Joshi, Dr. Minesh Jain, and Dr. Priyanka Patel. I hope I have not missed out on anyone.
Dr. Ramavat Dev is there?
Yes, sir,
Yeah.
I'm here.
Okay, wonderful.
Dr. Ashish Joshi, is he there? Minesh Jain, I just saw. Priyanka Patel and Sai Vivek.
Yes, ma'am, I'm here.
Yeah, and Dr. Bharat Rangarajan is there. Right. Yeah. So we'll have a panel discussion on HER2 positive MBC.
Ma'am, one more panelist is there. Dr.
Yes.
Srivalli.
Srivalli.
Yes, ma'am, I'm here.
Yeah, okay.
Dr.
So
Kurusi, before we
let's
begin,
begin quickly with the case. So this panel discussion is aimed at actually choosing what is the right therapy first in the first line, and we are all aware of the data on that, and then subsequent lines of therapy. How do we manage brain metastasis, which is still the biggest challenge in HER2 positive breast cancer, though we have made long strides in this last decade, and the treatment sequencing in the era of newer targeted anti-HER2 therapies. So, coming quickly to the case, it's a 55-year-old postmenopausal woman, and she was, detected on mammography to have. She had no significant medical history except for diabetes, which was controlled. She was nulliparous, and she did not have any family history. And the physical examination, she had a palpable left breast mass and axillary lymphadenopathy. The core biopsy showed an ER/PR negative, HER2 positive by IHC, and FISH positive. The brain MRI was negative, and the PET CT and bone scan revealed multiple lesions in the spine, pelvis, several pulmonary nodules. Pulmonary nodule biopsy revealed an invasive ductal carcinoma, ER negative and HER2 positive. Now, the first question I'd like to put to the, my panelists. So let me begin with Dr. Bharat. Would you do first of all a brain MRI in all metastatic HER2 positive breast cancer patients?
The PET is showing metastatic disease, and if the PET does not show any brain metastasis, I would prefer to do MRI scan also to complete the staging, because we have assessed the other sites of metastasis with the PET scan. We may miss smaller lesions in the brain, and leptomeningeal mets. So in a metastatic disease, I would prefer, because that may actually make a difference on how aggressively we are going to treat and how we are going to follow up the patient.
Yeah. So now, if we see this, I just want to know, I suppose, all of you have access to fish testing, which was mentioned in by the previous speaker. If anyone doesn't have an easy access, you can just raise your hand or, speak up and say what are the difficulties. So anybody? So since nobody really has a difficulty, let's move on. Which treatment option would you recommend in this patient as a first-line therapy? ER/PR negative, HER2 positive, metastatic breast cancer. So here are the options. So let me begin with Dr. Krupa Shankar. Is she there? Dr. Krupa Shankar. Then Dr. Sai Vivek.
Yes, ma'am. So in this particular patient, post the MRI, which I would also definitely do, I would start off with trastuzumab, pertuzumab, and a taxane as per the Cleopatra data, de novo metastatic HER2 positive breast cancer.
Yeah. So Dr. Dev and Dr. Ashish Joshi, do you agree with this first line?
Yes, ma'am, I do agree with the first line. The dual blockade is definitely better than the single blockade, as we have seen. Now we have enough evidence to support this strategy. So I would go ahead with my previous speaker.
Dr. Minesh Jain, of course, this
prefer-
is just a question on the side, that would you consider the IV or the subcutaneous form, since
I prefer subcute, because that becomes easier. So we
Yes.
give Phesgo. That becomes an easy thing, and then Taxans is anyway an easy option. So this is what we do generally. We use Phesgo.
So this is the Cleopatra study, and now you have the 8-year results and the follow-up, which was actually published in the year 2020. This is the end of the study, overall survival in the intention to treat population. And as you can see, that in this landmark, overall survival was 37% at 8 years on the combination arm, as opposed to on the trastuzumab alone, it was 23%. So the dual inhibition was really better even at the 8-year mark. And if you look at the median PFS at the 8-year mark, again, the landmark PFS was 16% in the experimental arm versus, the 10% in the trastuzumab with chemotherapy alone arm. So definitely, it was, the dual anti-HER2 blockade in this setting along with chemotherapy was superior. And that is what all the panelists have chosen as their first line. So she was started on paclitaxel, trastuzumab, and pertuzumab, and follow-up imaging at 3 months. And denosumab was also started in view of skeletal events. Now, I just want to ask Dr. Shivali that are we justified in substituting docetaxel with paclitaxel in this particular regime?
Yes.
Yes, ma'am. It is because we have evidence that even paclitaxel also has got a good response.
Yeah.
So
Yeah.
I think yes, ma'am.
Yeah, so there is a real world data where they have looked at even NAB, PACLI, and DOSI, and they have equivalent results. So you can substitute the taxane. So now this is the thing that we started with this regime in Jan of 2020. And after 18 months, she developed dry cough. Imaging showed that there was progressive bone disease and multiple new pulmonary and liver nodules. So now we come to the next. So which treatment option would you recommend now? So can I start with Dr. Priyanka Patel?
Yes, ma'am. Hello, ma'am.
Yes.
So right now, of course, previously, without the availability of trastuzumab deruxtecan, we were using TDM1. And we do have TDX available now within like last 2 months, and we do not have any clinical experience apart from clinical trial. So I would definitely like to offer TDXD with keep in mind the toxicity which we usually faced with TDXD as the clinical trial data of ILD mainly.
So Dr. Bharat, could you just allude to the data which, has made TDXD, as now the second line choice of therapy in the metastatic setting?
This is a lady who has had nearly 18 months of response to trastuzumab, pertuzumab based therapy, and she more than 6 months, and so she would definitely benefit from TDX, that is trastuzumab deruxtecan, based on the if we are looking at the accrual for the Destiny Breast 3 trial. She has, however, small volume progression, in the sense that she does not have brain metastasis, she does not have new site of disease. She only has disease that has pre-existing, which is increasing. She would definitely fit into the Destiny 3 category, who had almost everybody had received previous pertuzumab, and we can go ahead with the TDXD, of course, if the affordability allows for it.
Yeah. So, Dr. Sai Vivek, are you aware of some data that what is the efficacy of TDM1 versus TDXT in patients who have received a prior pertuzumab? Because some data has come out on that.
Yes, ma'am. There
Yes.
are a couple of Italian and I think other real world evidence studies also, which says the data for TDM1 was mainly for patients who hadn't received pertuzumab. So if you receive pertuzumab in the first line setting along with trastuzumab, the difference, the benefit of TDM1 is minimal, or sometimes even it can be counterproductive also. So with all those evidences collected, I think with the availability of TDXT for the best response and the next best PFS2, I think TDXT is the way to go.
Yeah. Yeah. So, this is the importance that, on the Amelia study on the left-hand side and the Destiny Breast 03. So the Destiny Breast 03 is the study which really put it ahead of TDM1 as the second line choice of therapy. And as you can see that those with TDXT did much better with a hazard ratio of 0.028 as far as the PFS was concerned. And this is a very striking difference. And that is how it has got the approval as a second line therapy. And then this is the data that Dr. Sai Vivek was alluding to, that what is the effect of prior pertuzumab therapy. And these two Italian studies showed that patients who had prior received pertuzumab did worse on on TDM1. And you can see that in both the studies, those who are pertuzumab naive had a much better PFS, median PFS, as opposed to those who were pertuzumab exposed. And it was a significant difference. And the difference is seen also in some of the other studies. And you can see also in the Emilia study, it was 9.6 months in those who were pertuzumab naive. So, our patient had received pertuzumab for 18 months. So, TDXT again would be the drug of choice based on this data. And of course, one of the reasons given is the reduced expression of HER2 in patients who have received the dual pertuzumab trastuzumab therapy, and that may be the reason. And you know that TDM1 activity, there is very little bystander effect as opposed to TDXD. So, if there is a reduction in the HER2 overexpression, then it would affect the efficacy of TDM1 and not TDXD, which, as we know, is also approved for HER2 low metastatic breast cancer. So, as I said, the PFS according to prior pertuzumab therapy, as you can see here, that irrespective of that, the patients benefited on TDXT. So the patient then was started, of course, here in February 2022 on TDM1, because that time TDXT was not available in India. And then, of course, there is no need to ask, all of you have chosen TDXT. So if it was available at that time, wherever possible, if financially feasible, it would be used. So that is what happened. And then again, the patient had progressive disease. And then also TDM was started. And then there was a headache with brain MRI at that time, showed 3 lesions less than 2 centimeters. And she received SRS, and the bone scan also showed progressive bone metastasis. So what will be your choice of systemic therapy in brain metastasis? I mean, first, let's go to the approved options. So can I ask Dr. Kripa Shankar or Dr. Ashish Joshi? Then
Both are not there. You can
okay,
ask
then Dr.
Dr.
Minish
Ramav.
Jain.
Minish Jain sir and Ramav sir is there.
Yeah, so
Okay.
Dr. Minish Jain.
If there are brain metastases and they are the only areas of progression and there is no other progression, we have also treated some patients by giving SRS to the brain and continued with TDM1 because there was no other choice available. But the technical choice which is available to us, if there is a progression, then we can use TDX or we can use tucatinib along with trastuzumab and capecitabine. So these are things which can cross brain and they can be used for brain metastasis. So
Yeah. So here I'd just like to put another question, that if a patient is treatment naive and is eligible for, in the first line for pertuzumab, trastuzumab, and taxane, but has brain mets at presentation, would your choice of therapy change? Can I ask Dr. Bharat?
Probably brain mets at presentation in a de novo patient, madam. Patient was
Yes.
not received anything. No prior anti-HER2 therapy.
Yes.
At this point of time, I think even in such patients, we would go with the same combination of pertuzumab, trastuzumab plus a taxane. However, having said that, the original Cleopatra trial did not have many brain metastasis patients.
Yeah.
But as of now, we don't have data to initiate a patient um, on other agents. We don't have first line therapy with brain mets or without brain mets to use other agents.
Yes. So
Though
that's
I do feel that agents that cross the brain, like tucatinib or trastuzumab deruxtecan, will move up to the first line. I know that Destiny 9 is now accruing for first line metastatic patients. Even in India, it's accruing, but we
yes.
don't have the data to change our practice yet.
Yeah. So yeah, Destiny 12 is looking at that. And this is very important that, we don't have the data. And as far as we know that in the Cleopatra studies, patients with brain metastasis were excluded. So we don't have the data for the efficacy of pertuzumab. Although all the studies have shown that the use of pertuzumab and trastuzumab as opposed to trastuzumab alone has delayed the CNS progression, and the median PFS is slightly longer on the dual versus the single, but that is very indirect data since all the patients were excluded from the Cleopatra study. So as of now, we would have to stick to the same first line. So this is the HER2 climb data, and you can see that 22% of patients had untreated brain metastasis in the tucatinib arm. Total, there were almost 198 patients with brain metastasis, whether they were treated and stable, untreated, or treated and progressing, as seen over here in this particular subgroup. And then, of course, if you look at the progression-free and overall survival outcomes, you can see that the hazard ratio was for progression-free survival was, this is in the overall population. It was much better with the inclusion of tucatinib as opposed to the placebo arm, both in regards the PFS as well as the overall survival. And there was longer PFS with tucatinib in the overall population. And if you look at those with the brain mets, this is the updated overall survival in patients with brain mets. You can see that whether they were brain mets which were treated or active brain mets, the hazard ratios were very much in favor of the tucatinib arm. And there was a reduction in the chance of death by almost 50%, and of progression-free survival, the hazard ratio was 0.34. So that means almost a two-third reduction in the chance of intracranial progression. So these are the very telling data from the HER2 climb, and that has made it one of the forerunners for patients with brain metastasis in HER2 positive who have received prior therapy. And so this is the Destiny 03 study, and you can see that here too, if you look at the survival curves in patients with brain metastasis, the TDXD arm did much better than the TDM1 arm, showing that there is activity for TDXD in this population. And even with no brain metastasis at baseline, you know that the PFS was better. So patients were included if those who had brain metastasis that were treated and asymptomatic. So you had 16.5% of patients in the TDXD arm and 14.8% in the TDN arm who had brain metastatic as presentation. So the intracranial response from this study, it showed that the CRPR was much better with the TDXD arm, and even the progressive disease was much less with the TDXD arm. So definitely this is an indication also of the activity of TDXD in this patient population. So that is what Dr. Bharat was alluding to, whether this would move up front. And this is a retrospective exploratory analysis, pooled analysis. So can I ask Dr. Vivek to just say something about this data?
Yes, ma'am. So
Yes.
I think with the pooled analysis of Destiny O1, Destiny Breast O1, O2, and O3, so what we know that is compared to the previous standard of care, what we had, we know that TDXT obviously has better responses in the patients with brain metastasis compared to any comparator. Just that at this point, as we were discussing, we don't have strong enough direct phase 3 data to use it. But I would say tucatinib, looking at the data from HER2 Climb and this, I think there would be a fork in our treatment decisions where if predominantly the disease is in the brain and also systemically, we could in the future, when tucatinib is available, choose tucatinib and then keep TDXT for later. But if predominantly the disease is systemic, do the other combination around. I think both of them are wonderful molecules, and there's enough evidence from this pool data that it does have intracranial response. So that is what we are looking for in a patient with brain metastasis, how quickly we are able to symptomatically make them better if they do have symptomatic mets.
Yeah, so you can see even those with treated and stable mets and untreated active brain mets, the response rates were almost similar. So were the complete response and partial response. And compared to the standard of care arm at that time, the comparator arm, you can see the responses were, far inferior. And these are all the CNS activities of the HER2 directed therapies. So this is a busy slide, but an important slide. And of course, now I would just come to one question. Dr. Minesh Jain, we don't have access to tucatinib. It's a little difficult and it is expensive. So in practice, what would you use in this situation?
In the first line, madam, I use the standard treatment,
Yes.
pertuzumab, trastuzumab,
No,
and
I'm meaning in this patient at this present time. Now, the patient has progressed on TDM1. So you don't
TDX.
have tucatinib.
TDX.
So
I would use TDX.
yeah, but you would use TDX. Yes. What about suppose the patient can't take TDXT, then what would you use?
Then I would give paclitaxel and Herceptin.
Yeah. So, Dr. Priyanka Patel, what about the use of lapatinib and capecitabine? I mean, I know that now one would not use it in the presence of all these, but sometimes we are it has to be used because of the circumstances. So, Dr. Priyanka Patel?
Yes, ma'am. So we do use, of course, with the availability of TDXD, now we would prefer definitely TDXD,
Yes,
even in third line. But previously, when some of our patients are not affording even for TDM1, with the availability of generic, also this has also reduced. But we do use lapatinib, capecitabine in third line with patients with progressive brain metastasis with the response rate of maybe 20-30%. And some patients do have poor tolerability of lapatinib drug full dose maybe. But this is a good option in patients who do not want specifically injectable treatment or sometimes. Then maybe we can use lapatinib and capecitabine.
Yeah. So,
You conclude in 2 minutes.
yeah. So, just one more question that, you're using SRS and then if there are extensive brain metastasis, whole brain radiation. So, yeah, can you tell us, Dr. Bharat, is it safe to use this concurrently with radiotherapy?
Concurrently to use TDXD, ma'am?
With radiotherapy, suppose you have to give SRS or even sometimes because of extensive brain mets, you're giving whole brain radiation. So is there some data on the concurrent use of anti-HER2 therapies and radiation?
I am not aware of any data per se, ma'am, but usually when I'm giving whole brain RT or when I'm, starting the patient on SRS, I send them for the radiation and then they come back after the radiation is over after a week or 2 weeks and then we start.
Yeah.
There could be data which I'm not aware of, ma'am. I'm not aware of the data.
Anybody else in the panel would like to comment on this? What do they do in practice? Do they give concurrently or sequentially?
So whenever patient is on radiotherapy, I think there is a data to suggest that we use HER2 blockade therapy like trastuzumab or pertuzumab concurrently, but we don't tend to use chemotherapy at that point of time. Maybe we give 2 to 3 weeks of gap after radiotherapy and then add chemotherapy if we are using.
Dr.
But,
Minesh? Jain, what is your practice?
I have used targeted therapies, including TDM1 during radiation. But if I've had a patient who had a lot of meds and I was suspecting brain edema to be an issue, then I've delayed my treatments for a week and allowed them to settle down with the radiation and then started it. So if it was just a trastuzumab lapatinib or pertuzumab trastuzumab, or if it is even TDM1, we have used it in some patients along with radiation. If we find that because patients who were progressing on TDM1 with brain mets and there was no option available to us, we have given radiation and TDM1 concurrently, means maybe 1-2 days here and there.
Yeah, so there is some
Data, yes, madam.
Yeah.
Sorry,
That-
madam. There is
yeah.
data that ADCs and radiation, especially to the brain, can cause adverse events. Trastuzumab and pertuzumab is fine, but I think some necrosis or certain
Yes.
adverse events, I remember reading that,
Yes.
especially with TDM1
Yes.
and
So-
TDXT being a stronger ADC, I think we should throw in some caution, especially during the time of radiation.
Yeah, so very rightly put, we can use trastuzumab, we have used even lapatinib, but as far as TDM1 is concerned, there has to be a caution because radionecrosis is seen in more than 50% of patients. And we don't have the data with TDXT, but I think being an ADC, we might be having similar effect if used concurrently. So this is
Ma'am,
the
I'll
thing.
just add to it. The
Yes.
patient, we have seen this necrosis happening in especially with SRS, and we have used steroids in later date for these patients, and we thought that they were progression, but it was radionecrosis. So
Yes.
even without TDM1 being given together, we have seen the radionecrosis happening, even if you have used it subsequently.
Okay. So I think we have run out of time. So there are a number of drugs regimens for HER2 positive, and we have learned from this panel, who have really shown us the way of how to sequence and how to deal with brain metastasis. And of course, I think this question is now not relevant because you have already answered it that you would use TDXT in the second line. And with this, I think you have also answered this question that you would prefer to use it in the second line. And with that, I would like to thank the organizers for giving us this opportunity to discuss the HER2 positive MBC in the context of all the new therapies and addressing the issue on brain metastasis. And I would also like to thank the panelists for their very active, role in this. Thank you.
So thank you very much, Dr. Smriti, and all the panelists for wonderful discussion. I'm sure the next talk or the panel discussion after that will include the discussion on HER2 Climb 2 data as well. So now we have Dr. Paolo Tarantino from Harvard Dana-Farber Cancer Institute in Boston in USA. He has done his medical degree from Naples in Italy, followed by oncology training at University of Milano in Italy. Currently, he is advanced research fellow at Dana-Farber Cancer Institute in Boston. He is specializing in breast oncology. He has more than 50 publications on breast cancer, and he is also pursuing PhD from University of Milano in addition to his current assignment at University of Massachusetts. So, Dr. Paulo, please have your talk about the current landscape of anti-HER2 therapy in metastatic breast cancer.
Thank you for this kind introduction, Dr. Desai. Thank you for AstraZeneca for inviting me at this talk. Give me just please a second to share my presentation. And here we go. Oops, sorry. All right, so I've heard wonderful discussions about the management of HER2 positive breast cancer in the prior session. And I think it was inspiring to see in the last 2 decades so many approvals in that setting, recognizing that in about 15% to 20% of the patients, and the HER2 oncogene is amplified, and you have this overexpression of the proteins, and you can block it with many different agents, has really changed the trajectory of both metastatic and early stage HER2 positive breast cancer. But actually, we have to remember that most of the patients that we see in our clinic have got HER2 negative breast cancer. This is the most common breast cancer that we face and that we have to treat. And usually we divide HER2 negative breast cancer into hormone receptor positive, of course, and triple negative, which have very different features. And in the beginning, we treat them in a very different way, at least when they're metastatic. So hormone receptor positive HER2 negative breast cancer, we tend to utilize endocrine treatment first with biologic treatments like CDK4/6 inhibitors, everolimus, alpelisib, many other agents. But once the disease becomes clearly endocrine refractory, the main treatments that we have are chemotherapies. And same for triple negative breast cancer, although here we cannot use endocrine treatment. What we have is chemotherapies, with or without sometimes immunotherapy. In certain cases, PARP inhibitors. More recently, ADCs are coming, but in general, chemotherapy remains the mainstay of treatment for patients with HER2 negative disease. And talking of chemotherapy, I think the elephant in the room is that chemotherapy, at least in the pretreated setting, does not work so well. So the trial that led to the approval of the latest traditional chemotherapy that was approved, eribulin, showed that it was associated with a response rate of 12% and a median PFS of 3.7 months, eribulin. And this was enough to approve the drug, but is it enough for our patients? I don't think so. I think we need something better. And that something better started to arrive with ADCs. First with sacituzumab govitecan that was approved based on phase 1 data showing a response rate of 35%, median PFS of approximately 6 months, then that these were confirmed in the ASCENT trial, but still there is room for improvement. Even here we're talking of less than 6 months PFS, there is room for improvement. And there is room for improvement also if you think that even if tumors that have HER2, that are considered HER2 negative, do not have their HER2 amplification, we know that these tumors still harbor some HER2 expression. We know that most of HER2 negative tumors actually are called HER2 1+ or 2+ at immunohistochemistry and have up on each tumor cell thousands of HER2 receptors. And so I think it's a good question to ask if they could still, these patients with these HER2 negative tumors that express some degree of HER2 expression, if they could still benefit from HER2 blockade. And one large trial was conducted started almost a decade ago to look at this question in the early setting. Can patients with HER2 negative breast cancer that have HER2 low expression, meaning IHC 1+ or 2+ non-amplified, benefit from the addition of trastuzumab to adjuvant chemotherapy? This trial, called NSABP B47, enrolled more than 3,000 patients randomized to chemotherapy with or without 1 year of trastuzumab, and the results were like basically overlapping curves in terms of invasive disease-free survival and overall survival. No benefit from blocking HER2 with trastuzumab in HER2 low breast cancer. And this really changed once we started sticking things to trastuzumab, once we started developing antibody drug conjugates, delivering something toward HER2 expressing cells. And the agent that really produced a revolution in the field recently is T-DXd, trastuzumab deruxtecan. We have seen the impressive data in HER2 positive breast cancer with this agent, but also I think it was very impressive to see the data, the early phase data, phase 1 trial, J101 in HER2 low breast cancer. So this data presented at ASCO 2018 and subsequently presented on published on JCO in 2020, showed that T-DXd among 54 patients that were highly pretreated, a median of 7 prior lines of treatment for metastatic breast cancer with HER2 low expression, achieved a response of 37% response rate and median PFS of almost 1 year, 11 months with T-DXd. So this was basically the same population that I mentioned before with the eribulin. Of course, that was a large phase 3 trial. This was a small phase 1 trial, but if you look at the waterfall plot, nearly all the patients derive a shrinkage of disease with T-DXd. So highly encouraging, warranting further testing. And also other NTR2 ADCs different from TDXT, achieved responses in HER2-low metastatic breast cancer. Trastuzumab deoxyribonucleic, which carries an alkylator as payload, disitamab vedotin that carries a microtubule inhibitor as payload, trastuzumab rezetecan that harbors a payload similar to DXT, a topoisomerase inhibitor. All of this drug has more than 30% response rate, up to 60% response rate in HER2-low metastatic breast cancer, just telling us of how promising this field is and how targetable HER2 can be even in the absence of HER2 amplification. And this is why back in 2020, we proposed this kind of expansion of the pie chart of targetability of HER2 beyond the canonical HER2 positive subtype, encompassing further 50% or more of patients with metastatic breast cancer that have HER2 low disease, IHC 1+ or 2+ non-amplified. And one thing that is important to remember is that HER2 low expression is strongly linked to estrogen receptor expression. And so among triple negative breast cancer, 40% are HER2 low, and whereas the majority are HER2 zero. But if we look at estrogen receptor high, if the tumor cell express high percentage of estrogen receptor, there is much higher likelihood that the tumor is also HER2 low, more than 60%. And it's important to remember because every prognostic analysis, genomic analysis, everything needs to be corrected for this important confounder. So the trial that was designed and developed to kind of confirm the paradigm of targetability over HER2 low was DESTINY-Breast04. Many of you have most likely seen this data already. This was a pivotal trial of phase 3 trial enrolling patients with HER2 low metastatic breast cancer that had received prior endocrine treatment and 1 to 2 lines of prior chemotherapy. Most patients had hormone receptor positive disease, but there were about 10% of patients with triple negative disease, randomized 2-to-1 to TDXT versus traditional chemotherapy, with the primary endpoint being progression-free survival. And what you can see from the demographics, once again, 90% of the patients had hormone receptor positive disease, 10% had triple negative disease. Prior therapies were a median of 1 prior line of chemotherapy, 2 prior lines of endocrine treatment, so very modern cohort. About 70% of the patients with hormone receptor positive disease had prior CDK4/6 inhibitors. And in this population, TDXT more than doubled progression-free survival. PFS was 4.2 months with chemotherapy, 9.6 months with TDXT, for a statistical improvement and as a ratio of 0.37. And this was in the hormone receptor positive cohort. But if you had also a triple negative cohort, so in the old population, you also have a doubling of PFS that was statistically significant, and improvement also in overall survival, both in the hormone receptor positive cohort and in the overall population. You have approximately a delta of 6 months in overall survival with a hazard ratio of 0.69 that was statistically significant, both for the hormone receptor positive cohort and the overall population. This was the latest update of the data. Finally, in the exploratory analysis looking at triple negative breast cancer patients in this trial, only approximately 60 patients, but still you have a more than doubling of PFS, an improvement in overall survival of almost 10 months delta, just showing that TDXT can improve outcomes not only in hormone receptor positive, but also in triple negative metastatic breast cancer if you have HER2 low expression. What about side effects? With novel conjugates, we're seeing that we still carry payload-related side effects, and in this case, the payload is a topoisomerase 1 inhibitor, like irinotecan. And so what do we see? We see nausea, vomiting, diarrhea, neutropenia, fatigue, and alopecia, just similar to irinotecan. However, we are learning how to manage these, and I will cite some strategies to manage this. But it's important to remember also that approximately 12% of the patients receiving TDXT develop interstitial lung disease. And some of them, approximately 1%, can develop fatal ILD. And it's important to always monitor for this, as we will discuss. Whereas cardiac dysfunction is very rare, less than 5% of the patient had got it in the DESTINY-Breast04, but it's still important to monitor patients with echocardiograms every 3 to 6 months during treatments. So this data, as early as 2022, really reshaped the way we think of HER2 targetability. Not only the HER2 positive metastatic breast cancer is targetable with anti-HER2 ADCs, but also HER2 low, more than 50% of all patients with metastatic breast cancer. What is the current experience in clinical practice? So the experience we're having at Dana-Farber and Duke, we presented it last year at San Antonio Breast Cancer Symposium. What we saw is that T-DXd has the longest activity for HER2 positive metastatic breast cancer, approximately 11 months PFS, time to next treatment, whereas this was slightly short to 7.6 months for HER2 low, consistent with the trial data, and approximately 4 months for HER2 zero, because sometimes we're also treating patients with HER2 zero disease. One intriguing finding that we had was that depending on HER2 status, if it was stable in time, meaning the patient had HER2 low breast cancer on the primary tumor and on the metastatic tumor, that was the tumor that benefited the longest for T-DXd. Whereas if there was loss of HER2 status in metastatic setting, the activity was shorter. This was a small analysis, but I think very intriguing. And we also showed that numerically, patients that had HER2 hemizygous deletions in the gene had shorter time to next treatment of 4.1 months compared to 7.6 months in patients without this alteration. And also we conducted this DNA-DX analysis on plasma collected before T-DXd, and this novel signature seems to predict the activity of T-DXd. Finally, after T-DXd, most regimens seem to have 3 to 4 months PFS, which just highlights how we need to develop better drugs. And I'm sorry, I think there is some background noise. I don't know if it's possible to mute. And also, in terms of toxicities, we basically saw what has been seen in the trials. And approximately a third of the patient needs dose reduction. Approximately 15% of the patients discontinue the drug, most of them because of ILD. We had, just like that DB04, about 12% of patients developing ILD, but no grade 5 ILD in our real-world experience. What about other targets? The experience of T-DXd raised the hypothesis that we could further expand the targetability of breast cancer, not only to HER2, but to other interesting antigens that are overexpressed on breast cancer cells, like TROP2. TROP2 is actually overexpressed by approximately 50% of breast cancer, but there is some minimal expression in up to 90% of breast cancer. So a highly appealing target with differential expression between tumor and normal tissue. And this is why in time, several anti-TROP2 ADCs were developed. The first one was sacituzumab govitecan that is made similar to T-DXd. It's got about 8 molecules of a topoisomerase inhibitor, in this case SN38, linked to a TROP2-directed antibody with a cleavable linker. In this case, is an acidic cleavable linker that is less stable than the one you have in T-DXd, and so in this case you have an even shorter kinetic. The half-life of T-DXd is about 4 to 5 days. In this case, it's approximately 16 to 18 hours. And so within 1 day, most of the drug has hydrolyzed. And what, as I mentioned, in triple-negative breast cancer, the drug was first approved based on phase 1 data, showing 30% response rate in highly pretreated setting, which then were confirmed in the ASCENT phase 3 trial, for which recently there was an update in JCO showing that among patients with highly pretreated metastatic triple-negative breast cancer, sacituzumab govitecan compared to single-agent chemotherapy improved progression-free survival with a hazard ratio of 0.39 and nearly doubles overall survival from 6 to 12 months. More recently, in hormone receptor-positive HER2-negative metastatic breast cancer, in a similar population of patients with highly pretreated disease, with at least 1 prior line of endocrine treatment, all patients had CDK4/6 inhibitors, and a median of 3 prior lines of chemotherapy, sacituzumab govitecan compared to physician choice of chemotherapy, significantly improved progression-free survival from 4 months with chemotherapy to 5.5 months with sacituzumab govitecan, which was statistically significant, and also overall survival was improved statistically with a hazard ratio of 0.79 and a delta of 3.2 months, showing that these ADCs can definitely improve both PFS and OS compared to traditional chemotherapy. In terms of side effects, similar to TDXT, this is also based on a topoisomerase inhibitor. And so even more in this case, since the drug is even less stable than TDXT, you have more neutropenia, more diarrhea and nausea, and more fatigue than the one you see with TDXT. And also most of the patients receiving the drug, more than 90%, experience alopecia. And however, in this case, you don't see interstitial lung disease with sacituzumab govitecan. There is an important aspect that differentiates this agent from TDXT. So how do we sequence these drugs in the clinic? So for patients with hormone receptor positive metastatic breast cancer, most of the cases we still start with endocrine treatment with CDK4/6 inhibitors and other agents. So I think if the disease seems endocrine sensitive, using endocrine treatment first is always the right choice. And then after, when the disease becomes endocrine refractory, all of the ADC trials were conducted in chemorefractory settings. And so we still start with at least one line of chemo. But after the first line of chemo, TDXT is the best choice if you have HER2 low expression, which means in most of the cases. And then at progression to TDXT, sacituzumab or chemotherapy can be options. And if you have HER2 zero disease, you cannot use TDXT, but encouraged to always perform a new biopsy or reassess prior samples, because sometimes you can have HER2 expression that kind of pops up and develops in time. What about triple-negative breast cancer? Very similarly. After the first line of chemotherapy, without that immunotherapy, always think of ADCs, either TDXT or sacituzumab if you have HER2 low disease, whereas if you have HER2 zero disease on any prior sample, only sacituzumab govitecan is an option. Talking of interstitial lung disease, we are seeing this, of course, with TDXT, but also with several other novel ADCs. And what I think is very important is to remember about the 5S rules, that whenever you have a patient for which you start TDXT, you have to screen to understand if there's baseline lung comorbidities, to scan the chest of the patient every 6 to 12 weeks. For I think the ideal is approximately 9 weeks. Develop a synergy with radiologists, pulmonologists, and all the care team in order that whenever the patient develops symptoms, everybody can understand and suspect ILD. Suspend treatment with TDXT whenever there is an ILD that develops, and finally administer steroids if there is an ILD that has developed. What about nausea? In case of nausea and vomiting with TDXT, first of all, remember about prophylaxis. This is a highly emetogenic drug. The same is also for sacituzumab govitecan, and so I think it's important to use 3 drug regimens up front with dexamethasone, H3 antagonists, and NK1 receptor blockers. In addition, in some patients, low-dose olanzapine can also help to prevent and to treat and prevent nausea. As I mentioned, HER2 status can be unstable in time, and this is another challenge that we face. One tumor that is HER2 low can become HER2 zero, one that is HER2 zero can become HER2 low. How do we face this challenge? And how do we face tumors that, once again, can be HER2 low on the primary tumor and become zero? So the important thing, as I mentioned, is to perform new biopsies, because if the disease was HER2 low, it can still, if the disease was HER2 zero, it can still become HER2 low. The more biopsies you perform, the higher the likelihood that you find some HER2 low expression in the tumor. And what Destiny Breast so far has shown is that HER2 low status developed found on the primary tumor or in the metastatic setting, both can predict the benefit of TDXT. And also archival tissue or a most recent biopsy, both can predict the response to TDXT compared to chemotherapy. And of course, we performed this real-world analysis suggesting that patients with stable HER2 low status derive more benefit, but some benefit is still observed also with heterogeneous HER2 status in time. One important thing, since HER2 low status has become so important, it's extremely important to report the HER2 IHC score every time in the pathology report and also in the physician notes. We should never anymore write only HER2 negative, but HER2 negative should always be accompanied by the HER2 IHC status. And so once again, just to reiterate, I personally think of using TDXT whenever a patient has a tumor that has shown HER2 low expression on any prior specimen, on the primary tumor, at first metastatic diagnosis, or also the most recent diagnosis. You just need one sample testing HER2 low to think of using T-DXd in a patient. So I would like to conclude, and I hope I'm in time, so we have some time for discussion. So about 1/2, and actually more than a half of all breast cancers are HER2 low. And DESTINY-Breast04 brought T-DXd as a standard of care for these patients after at least one line of chemotherapy. HER2 low expression on any prior specimen should be considered adequate for offering T-DXd. And if you never had HER2 low expression, I think it's appropriate to perform an additional biopsy to see if there is some HER2 low status that develops in time. Sacituzumab govitecan is also an option if it's available in the country for patients with HER2 low and HER2 zero disease. But most importantly, now that we have these ADCs, we have to remember that these ADCs have side effects, have toxicities, and we have to prevent them and manage them in the best possible way in order for our patients to benefit of them and remain of them for the longest possible time. Thank you very much for your attention. Really looking forward to the discussion after my talk. Thank you.
So thank you very much, Dr. Tarantino, for the wonderful discussion on HER2 positive as well as HER2 low metastatic breast cancer. And thanks for completing a couple of minutes ahead of the time. That gives us the opportunity of having a couple of questions. And if I can start the question to you, Dr. Tarantino, if the patient has the germline BRCA positive, will you place T-DXd before or after olaparib?
It's a great question. Very hard to answer because we don't have any data that uses both. But what we try to do in these cases is to run polls within the institution. And so we did this at Dana-Farber. And what we realized is that most physicians, and personally myself, I also feel better about utilizing PARP inhibitors first, just because they are oral treatments. They have up to 50% response rate, they're well tolerated, and they allow to delay infusive treatment. So usually I prefer PARP inhibitors first, but using T-DXd first would not be a mistake. And so, for instance, if you need a fast response using something injective like T-DXd, it's still a good idea, I think.
I also believe that if the patient has brain metastasis, T-DXd will prevail over PARP inhibitors. Is that correct?
I agree. We have better data in patients with brain metastasis with T-DXd and with ADCs. So in that case, I would favor T-DXd over PARP inhibitors. I agree.
Great. Thank you very much. And any other question before we move to the panel discussion?
This is Dr. Bharat. Can I just ask a question on toxicity from the toxicity perspective? T-DXd seems to have quite a bit of interstitial lung disease, which you have highlighted in your talk. But for a non-trial patient, we have hardly any experience with the drug. For a non-trial patient, Dr. Paulo, how often do you do the CT scans? How often would you repeat, say, after the first 6 months, after the first 1 year? How long do you continue these CT scans? Because the grade 1 is impossible to pick up without a CT scan.
I totally agree that CT scans are fundamental to pick up grade 1. That is the most common presentation of ILD. And this is why we came to this consensus to perform CT scans in this window every 6 weeks up to 12 weeks, meaning between more or less 1.5 months and 3 months. My personal preference is in a fit patient, a patient without lung comorbidities, every 2 months, 2.5 months makes sense to perform CT scans. And I do that indefinitely. The patient always needs to be monitored while receiving T-DXd. If a patient has got some lung concerns or extensive lung disease, I prefer earlier. If I can do every 6 weeks, every 1.5 months, I think it's better, just like the trials have done. Whereas for a patient that received it for at least 1 year and has benefited from it without ILD, maybe you can delay a little bit and make the scans every 3 months. So it's kind of artisanal, but I think we always need to perform scans at least every 12 weeks. This is usually what we do. And what we notice is that we never had any fatal ILD up to now in our institution. And probably we were lucky because other institutions were not as lucky, but I also think that catching it early, interrupting the drug and using steroids really works to avoid severe cases. Thank you for the question.
Can I just
I have a question.
Don't mind. You can just ask. On this topic,
if the patient is found to have ILD early disease on CT scan, would you stop if the patient is asymptomatic from ILD point of view?
Yes, in this case, usually I stop, utilize steroids, 0.5 milligram per kilogram, and rescan. And usually what you see is that you have a fast improvement in the grade 1 ILD, and you can restart TDXD. If it's within 1 month, the improvement, you can restart at the same dose. Otherwise, you lower the dose. But in general, if you pick grade 1 early, treat it with steroids, it usually resolves rapidly and you can restart. If you have symptomatic, we tend to discontinue permanently, just like the guidelines recommend.
Thank you very much.
Yeah.
And then we will move to the panel.
I have a question, Dr. Chirag. Can I?
Please, Dr. Smriti.
Is there time for that? Yeah,
Yeah.
so I wanted to know about brain metastasis in the HER2 low population. What is the activity of TDXT intracranial in these patients?
So great question, and we have very little data for the moment. We have this small cohort of, I believe, approximately 10 patients from DEBRA, the Spanish phase 2 study, finding approximately 40% response rate in HER2 low intracranial response rate, which is similar to what we see with patients without brain metastasis. And I think in general with TDXT, this is what we see, that we kind of see the same rates of response in the brain and outside of the brain with TDXT. So in general, although we have very little data, I would say that for the moment, the data that we have, DEBRA, but also from DAISY, all of the studies have shown approximately 30 to 40% intracranial response rate. That is very promising, and I think much better than traditional chemotherapy.
And once the question was, in those who are HER2 low but ER/PR negative and have received prior immunotherapy, is there some additional toxicity with TDXT in those patients?
So it doesn't seem so. There were some analyses that were looked at if there is an increase in the risk of ILD after prior immunotherapy, and it doesn't seem so. And even when TDXT was combined with durvalumab, there didn't seem to be a high rate of interstitial lung disease, or even with nivolumab. So I was also worried of this, but the data seem to tell us that it's safe to use TDXT after prior immunotherapy.
Thank you.
Thank you very much. Dr. Kunal, will it be okay if we take your question in the panel discussion for the want of time? Right?
Sure. Perfectly fine.
Thank you very much. One of the point which very rightly was raised by Dr. Tarantino was that 62% of the patients who are HER2 negative traditionally and ER/PR positive, they are HER2 low in fact. So Dr. Raja is the next moderator. Dr. Raja is a dear friend and he is a senior medical oncologist from Apollo Hospital in Chennai. And he will begin his panel discussion encompassing the hormone receptor positive as well as HER2 low metastatic breast cancer patient. Raja, please invite your panelist and please start your panel discussion.
Thank you, Dr. Chirag. Thanks for this kind invite. Thanks to organizers. I just want to first check whether Dr. Sandeep Goyal I see, Dr. Kunal Sharma I see. Is Dr. Pushpak and Dr. Rana Sainath are available? Otherwise, I'm going to bug Dr. Chirag and Dr. Smriti for helping me out during the panel discussion. Please allow me to share the screen. I think it's visible.
Yeah.
Correct. Okay. Thank you. First of all, scintillating lecture by Professor Tarantino. So thank you, Professor, for enlightening on some of the nuances and a great insight. Thank you so much. We'll try to cover the points that were raised during these questions, some of the follow-up questions. I think that's exactly what we want to discuss in the couple of cases that we have. The first patient is a postmenopausal female who had a diagnosis of breast cancer and then treated on routine lines with docetaxel, cyclophosphamide, conservative surgery, radiation, hormone therapy. So she was actually ER/PR positive, strongly ER/PR positive, HER2 negative, IHC 0 at diagnosis. And then she was lost for follow-up for 5 years, and germline, hereditary breast and ovarian cancer panel was negative. And 5 years later, she comes back with severe back pain, suggestive of bone metastasis, and at that time undergoes these scans. And it was seen that she has pleural-based soft tissue density lesions. She's got other pleural and parenchymal nodules. She's got mediastinal nodes. She's got hepatomegaly and multiple liver lesions, and she has got multiple lytic bone lesions. And therefore, she was symptomatic. So at that time, a rebiopsy from the liver was ordered. And in the rebiopsy, the ER was 90% and PR 85%. And this time, it turns out that the HER2 is 1 plus. And the Ki67 is 60%, and GATA3 is positive. So this question is very, almost non-brainer, but I would still like to ask, in a typical clinical practice setting, do we routinely rebiopsy on all patients who relapse? In a very classical setting, this is an endocrine positive disease. After a 5-year follow-up on endocrine therapy, has typically relapsed. So it's really a copybook late relapser in breast cancer, endocrine positive disease. So does that make sense to rebiopsy always? So that's the question. I'll ask it to Dr. Sandeep Goel. But Sandeep, would you do it?
Yeah, so I would rebiopsy this patient first of all, because it's a long disease-free interval. Patient has been on therapy for the last 5 years without a recurrence. Secondly, the pattern with liver mets and lung mets again can show that the nature of the disease may have changed. And also to look for the HER2, because sometimes you have seen that the HER2 negative can become positive. So if there's a long disease-free interval, I would definitely do a biopsy, repeat biopsy, and then check for ERP and HER2.
Fair enough. I will ask the question once again to Dr. Pushpak. Dr. Pushpak has joined us. After the Destiny, 04 trial and the advent of HER2 low, I think our thought process may have changed. If I have to rephrase the question, do we rebiopsy on all our patients on a routine basis? Is that what we really do in clinical practice? Because not long ago, there were discussions in multiple panels that if I rebiopsy and if I see a change in the ER/PR status, and then if I act accordingly, does that produce a change in the outcome? So no, these were an often repeated discussions. So does that make? But now I think it's almost a no-brainer. But still want to hear from you, Dr. Pushpak. What would you do?
So usually in real world practice, any new lesion, metastatic lesion, we usually biopsy it again and we see the ERPR status, the HER2 status. There are few cases where we have seen the receptor status changing. But like you said, because of the newer modalities and the treatment options that we have, this process, if you have a shorter DFI, I feel that is where we could escape that biopsy. But if you have a longer DFI where there is a big gap between the recurrence, I think then it's justified that we do a biopsy again.
We'll turn to Professor Tarantino. Outside of a clinical trial setting, before the Destiny data set, what was the practice of rebiopsy in their setting? And obviously, now with the knowledge of HER2 low, and if the previous tissue is available, would they routinely go back and recheck the HER2 in the previous biopsy and the current biopsy? And this is a wonderful paper that he himself authored. We know this. So his thoughts on rebiopsying and checking HER2 on both the prior biopsy and the new biopsy, Professor Tarantino.
Thank you. This is a great question, and of course, I agree with all the what has been said up to now by my esteemed colleagues. And in general, even before DB04, I used to biopsy any patient that has a first diagnosis of metastatic disease, just because you want to know what you're treating. And some changes that may occur is that the tumor lost the estrogen receptors, and so maybe you don't want to use fulvestrant, something like that. Some rare cases, but not too rare, almost 5% of the cases, you have an acquisition of HER2 amplification. And in that case, the tumor becomes HER2 positive. Suddenly, you have so many new treatment options. And then you have this HER2 low thing. If the tumor was HER2 0, you do want to see if some HER2 low expression has appeared. And this happens in approximately 30 to 40% of the tumors that acquire HER2. And that will open for the use of TDXD in the future. I don't look back to the prior tissue if not needed, if I find HER2 low somewhere else. But if all the samples are HER2 0, I kind of ask the pathologist, like, is it possible that some prior tumor was defined HER2 0, but now knowing about the importance of this biomarker, giving a second look could raise some HER2 low expression. So I agree that DB04 has changed a little bit this approach, but even before, I always tried to perform a biopsy of the new metastatic disease, just like my colleagues.
Thank you. I ask our pathologist, Dr. Kunal is a very eminent center of excellence, about this whole question of discordance or concordance. Even if you look at the Destiny 04 data, there has been a discordance between the center that which was testing and the central testing and the local testing. There is still a little bit of discordance. I would say the concordance rate is something like 88%, but that would mean that there is still 10% there could be a discordance in the testing results as far as HER2 low goes. Dr. Kunal, your thought process on checking on the old biopsy, new biopsy, and the Dr. Torrentino talked about the migration of the results, but I'm asking about the discordance between the laboratories in this setting, HER2 low setting.
So, sir, there is, HER2 is one of the most, one of the first markers to be validated in a laboratory, and also one of the most discordant markers in terms of results that we get. Primarily, what is important is to understand that, with regards to HER2, validations have to be very, very strict because the reporting algorithms are very clear when we look at ASCO-CAP guidelines. So most of the discordance that happens is because of pre-analytical variables and the kind of clone that is being used and the way the test is being run. So that is on the side of the discordance. With regards to testing of samples in a metastatic setting, especially the samples which have shown hormone receptor positivity, we all know that in a recurrent setting, HER2 0 very often becomes HER2 low, especially if you see a PR positive case. The implication increases all the more, and now that
Dr. Kunal, I think there is a bit of a disruption. I see that you are traveling in your car. We just lost you on the last bit. Can you repeat
so,
it?
sir, yes. Am I audible now, sir?
Yeah, you're audible. Yeah.
So that was with respect to the discordance, sir, that I think mainly it is the pre-analytical variables and the clone of HER2, which is.
Okay. I'll ask. Thank you. I think Dr. Smriti Madam, if you are there, if there is a discordance between the original biopsy and the re-biopsy, of course there is this ESMO ABC guidelines are there. Will you be slightly hesitant in throwing in an expensive drug, Dr. Smriti, when there is a discordance between the original biopsy and the re-biopsy, Dr. Smriti?
So, I was part of this panel for the ABC5, and this was a much debated topic. And, the conclusion was that even if you had a discordance, regarding to the targeted therapy, at some point of time, you would still use that targeted therapy, even if it was in a previous biopsy setting. So even if I were to get an IHC 0 now, but at some point of time, it was, IHC HER2 expression low, I would still give that patient, the TDXT in the proper setting.
Okay, so that's a very valuable insight, and that's what the ABC5 did say. Dr. Chirag, would you, at this point, would you want to put this patient on progression now? If the patient has a IHC 2 or IHC 1, would you want to, now choose the second line, trastuzumab deruxtecan as the standard of your care? What are your thoughts, Dr. Chirag?
So I will ensure that the patient is not a candidate for a hormonal therapy. That is the first thing. So that will come through two things. Of course, hormone receptor positivity and the clinical setting, the symptoms of the patient, the level of organ involvement. So not necessarily visceral crisis, but if the patient has the liver metastasis and altered liver function, significantly altered liver function, I think I will push TDXT ahead of hormonal therapy. In other way, not exactly TDXT, I will ensure that endocrine therapy is exhausted, at least one line of chemotherapy has been given, and then I will go to TDXT.
That's an interesting thought. I'll ask Professor Tarantino. This patient would go on to receive, CDK4/6 inhibitor, and then has eventually gone on to receive the TDXT. But as my colleague was pointing out, if I find that the patient has got a IHC2 and has got some clinical visceral disease and has received one good hormone therapy, but has not yet gone into CDK4/6 inhibitors. So are there data to say between CDK4/6 inhibitor and the TDXD, is there a way to choose, Professor Tarrant?
It's a good question. We know that TDXD is extremely effective in this setting, but also CDK4/6 inhibitors are. And I think the best data we have here are from this phase 2 trial called Right Choice that tested endocrine treatment plus ribociclib as first-line treatment for patients with aggressive metastatic breast cancer. So with extensive liver involvement, with increased liver function tests and things like that. And they showed that basically endocrine treatment plus ribociclib was at the same response rate, 60%, and longer PFS than multi-agent chemotherapy. So I feel that it's very uncommon that I prefer starting with chemotherapy or TDXT, really just if the patient really fits the visual crisis scenario. If really there is a major increase in bilirubin, in other things that made me believe that the patient may not receive another line, I try the best I have, TDXT. But if I can afford to use a CDK4/6 inhibitors, I always do, because then I can leave other options for later. And if I don't use CDK4/6 inhibitors early, I rarely tend to do that late. So in this case, most likely, I would agree with utilizing fulvestrant and a CDK4/6 inhibitor. My preference usually ribociclib or abemaciclib.
Fair enough. So this is very, very impressive. Destiny-04, you shared it. You showed the PFS, you showed the OS. But if I can slightly push you further, how far would you push with the endocrine options? Should I exhaust every available endocrine option? No, it is absolutely okay to use the first-line CDK4/6 inhibitor. But then again, on progression, it's also okay to use a second-line endocrine option. So how far would you bet on endocrine if you have the IHC2 looming in front of us? So that will be the question to you, Professor Tarrant.
It's an important question. I wish we had biomarkers.
Yeah, first line you were very confident, but first line you said no other choice. But if I have to push you further and say, what about second line?
So I feel in this case, we are kind of already talking about second line, meaning that the patient recurred on aromatase inhibitor. So we're talking of using fulvestrant with CDK. And so I think I would still try to utilize at least one more line if the disease allows me. If there is no fast, major visual progression that really is telling me clinically that the patient needs chemo, I would try to understand if the patient can benefit of further endocrine treatment with either the combination with alpelisib or capivasertib, or with everolimus, or with another CDK4/6 inhibitors. I don't do that often, but in selected cases, or in some cases with elacestrant. So it's not that all the patients will benefit of this. Some patients after progression on CDKs have a fast visual progression that requires to move on to chemotherapy, to ADCs. But if instead the patient responded well to CDK4/6 inhibitors and fulvestrant, the clinical scenario is stable, I try to give at least one more. And that one more is based on genomic landscape. So if you do a ctDNA, if it's available, that can help, but also the clinical landscape, in which organ the progression occurred, and if the patient is clinically stable, of course.
Yeah, that's a great answer. But you mentioned about ctDNA. I just want to understand how would you, I mean, this year ASCO, there was a presentation that based on ctDNA, you can change your endocrine therapy to the next line. But here, how will ctDNA help you to choose between the second endocrine option versus moving into any one of the ADCs? How will the ctDNA help us? If ESR, I mean, you said genetic sequencing, if ESR1 is present, it's going to tell me that there is a endocrine resistance there. But other than that, how does a sequencing or a ctDNA going to help me to answer that question, Professor Taranti?
So I think the main way is performing ctDNA after progression on CDK4/6 inhibitors tell you a few key genetic profiles. It tells you about ESR1, and if it's mutant, you can think of oral SERDs or other degraders of the estrogen receptors that work better than aromatase inhibitors and fulvestrant. Then it can tell you about PIK3CA status, PTEN status, and AKT status. And now, if you have alteration in these three genes, you can offer capivasertib. And then it can tell you about BRCA. And if the patient has germinal BRCA mutations, of course, you can use olaparib or talazoparib, but we found some high activity also in somatic BRCA mutations. And then there's some upcoming ones. There is HER2 mutations, and there seems to be activity with fulvestrant, trastuzumab, neratinib. There are some rare, but not impossible to find alteration, like TMB high, MSI high. And so in general, I feel that there is, and then there are some associated with resistance, like RB mutations. If you have mutation in RB, you would not use CDKs again, because you know that CDK4/6 inhibitors don't work so well. So I think it does help to understand what to do after the first line, but you also have cases where you just have non-targetable alterations, and the best you can do is just like treating patients according to guidelines, to gut feeling, and to the clinical scenario. It's not uncommon, but I think the setting where ctDNA helps the most is after CDK4/6 inhibitors, because there you have kind of this rainbow of options, and you have to pick the best one, and ctDNA helps there.
Excellent answer. You talked about ER, you talked about RB. That's a great insight. So in the same setting, is there a use in doing the mRNA of ERBB2, and with that, would that help? If you do that, would that help to choose if you have an IHC 0 or 1 and ERBB2 mRNA, would that help? Do you have the facility to do that?
So unfortunately, we don't have much data about the utility in clinical practice of HER2 mRNA. It's an intriguing question because you may stratify HER2 0, but in truth, right now we don't have enough data to do that. That said, we await soon the data from Destiny Breast 06, that is looking also at TDXD in patients with HER2 ultra low, so HER2 zero with some HER2 expression. And so I do feel that in the future, we're going to broaden the use of TDXD, but not yet. So right now, I would not use mRNA.
Thank you. So I have another patient. This is a lady who presented to us in 2019 and then goes through the standard line of treatment. She was ERPR positive, but she was low ERPR positive, around 8%, and HER2 negative at that time. We treated her with AC followed by taxane, and then put on endocrine therapy with anastrozole. And then 3 years later, she progresses on bone and lung. She goes through, and as I told you, low ERPR, HER2 negative, so we treated with Pacli carbo. But then later on, we put the patient on fulvestrant and ribociclib, and we did the sequencing. So we got this PIK3CA, ATM, BRAF, NF1, and so on and so forth. So then we treated this patient with classical H1047 mutation. So therefore, we put the patient on alpelisib with fulvestrant, again, achieved a partial response with that. Now, after 8 months, the patient progresses once again with partial response, continued with alpelisib, but progresses thereafter. Increase in lung nodules and bone metastasis and lymph nodes. None of these were actually biopsyable. So that was the trouble at this point. This was in October 2022. I'll come back to my panelists. I'll come back to Dr. Priyanka, if you are there, if you can answer. Priyanka Patel, I see you are there. If you're interested, this patient has been treated with endocrine therapy, CDK4/6 inhibitor, and alpelisib, and has progressed and has lymph nodes, lung nodules, and I can even show you those pictures, were not exactly biopsyable. What would you do?
So right now, I think because we have used CDK4/6 inhibitor, alpelisib, PIK3CA, the targeted options and hormone therapy available right now, and foundation one didn't the BRCA and everything was negative. So I think we are left with chemotherapy.
Okay,
and there is,
that's your choice. Fair enough. That's what I want here. Dr. Sandeep, what would you do here?
So this patient looks like, that ER weak positive, so maybe sort of triple negative kinds. I would go for chemotherapy.
Dr. Pushpak?
Yes, sir, I agree. So with the current disease progression and liver which is involved, it could the visceral disease is there. So I could prefer the chemotherapy as of now in current practice. But there is also a role of ADCs, I feel, which we can use.
Yes, absolutely, Pushpak. That's what we had already exposed this patient to Pacli carbo. So we put this patient on sacituzumab. But after sacituzumab, again progress. Again, as per Dr. Professor Tarantino showed the eribulin data, we put the patient on eribulin, again progressed. Okay. So then we went, this time the progression was in the liver, and we could somehow biopsy these liver nodules, and you can see now that the ERPR is still the same, but now we see that the patient has 2+ HER2 positive. So the question is, it's very easy. Everybody would answer that we would put the patient on deruxtecan. That's what we did. Now the patient has shown excellent response to deruxtecan, and you can see that the patient continues to be in remission. This is after 4 cycles of deruxtecan, but still this was in the response was demonstrated in September 23, but the patient is still doing very well with deruxtecan. So my question to Professor Tarantino is that when there is a choice to sequence, this ASCO, there was a data on this on the sequencing between 2 ADC. If there is an opportunity to present sacituzumab and trastuzumab deruxtecan, by the choice of sequence, is there an outcome difference? So can you enlighten us on that, Professor Tarantino?
So it's one of the key questions right now in the field, and it's very easy to answer, I feel, for hormone receptor positive disease, because hormone receptor positive disease, TDXD has been studied in early lines, in patients pretreated with a median of 1 prior chemotherapy. And so this is why we tend to use it in second line. But sacituzumab govitecan was tested much later, was tested in patients that had 3 prior median lines of chemotherapy, highly pretreated. And so this is why I feel the clinical trials kind of guide us toward the answer of using T-DXd first, sacituzumab later. And based on the retrospective data we're seeing, you can expect a little less activity with the second ADC. First, because it's given later. Everything given later works less. And then because it does have a similar mechanism of action to T-DXd. But still, I feel if it's available, it's good to use it because these patients do not have many other active options. In triple negative disease, it's harder because after first-line chemotherapy, you have both sacituzumab and T-DXd that have been tested a little bit earlier. And I think the choice in my case is based on toxicities. You discuss with the patients that on one side, you have an agent that have shown very good activity in phase 3 trial, but has more than 90% alopecia, has got a lot of neutropenia, sometimes require growth factors and fatigue. On the other side, you have an agent which, with less alopecia, more comfortable, is given every 3 weeks, but that can cause interstitial lung disease. And so I think it's important to kind of offer both if they are available and deciding together with the patient. I think sacituzumab has got more evidence in support right now in second line, but using T-DXd is not crazy. And when I use them in sequence, I always prefer utilizing standard chemotherapy in between, just like it was done in this case. Because we just do this in oncology. You know, we try to alternate the mechanism of action of drugs. And I like, in this case, having eribulin in between the two ADCs.
Yeah, we did do this. We didn't do this out of great knowledge or anything. It so happened that the previous occasion we couldn't biopsy, so we were just desperate. And then later on, there was an opportunity to biopsy, and that's how we did that. So it's absolutely like we learned along the way, rather than that we were knowledgeable and we used it in this way as we did. This patient, but the highlight is that this patient has crossed a CDK4/6 inhibitor, and then fulvestrant alpelisib, and then sacituzumab, and then would eribulin, and then even at that much later line, has shown a tremendous response, excellent improvement in quality of life, and still continues to be in remission for nearly 1 year. So that is something that is very, very convincing for us to know that when there is a target, if it works, it works. So that's what happens. So now, if these patients, to ask, you have tremendous experience, what if they progress after deruxtecan? What do we do? Can you tell us what can we do? Can we go back to can we use tucatinib at that setting, having selected deruxtecan on an IHC2 or something like that? Or we justified in applying the HER2 directed therapies that are well defined in classical HER2 setting in patients? If this patient were to progress, how do I take it forward?
So unfortunately, right now, our understanding of HER2 low is that it's very different from HER2 positive. HER2 positive breast cancer is really addicted to the HER2 amplification. And so if you shut off the pathway with trastuzumab, pertuzumab, tucatinib, all of these drugs, it works. But in HER2 low, it's very different. HER2 is not, the tumor cell is not dependent on HER2. It's just something that is expressed on the cell membrane, like TROP2, like HER3 and other markers. But if you shut it off with trastuzumab, it doesn't work. If you shut it off with pertuzumab, it doesn't work. And most likely, what I expect is that also with TKIs, like lapatinib, daratinib, tucatinib, I don't expect great activity. We don't have the data yet, but I wouldn't do that. For the moment, for these patients, the best we can do is chemotherapy. And I think the trend is trying to bind, to link chemotherapy to different antibodies in order to deliver it better. And so maybe in the future, for this patient, we will have a Nectin-4 directed ADC. We will have a LIV-1 directed ADC, a B7H4. And so we try to use every target on the cancer cell to deliver a new payload. And the new payload can be chemotherapy, but actually there is novel fancy ADCs delivering immunotherapies, delivering protein degraders, delivering radioisotopes and many other things. So they're not here yet. They're in phase 1 testing, but I think they will soon. And so in this case, what I think we will do in the future is delivering something with ADCs. But HER2 targeted treatments in HER2 low, for the moment, I'm not so excited about that yet.
Thank you. So that's a great insight. So one last question is that, we know that when patients are triple positive, and when we use trastuzumab, even in the metastatic setting, we are happy to combine any one of the endocrine therapy along. Does that same mechanism idea work when we are using deruxtecan? Can I add on endocrine drugs just to keep those cells also under check? So do you have data on that? Do you have insight on that, Professor Tarantin?
So we have minimal data on this. There is a phase 1 trial, Destiny Breast 08, that combined TDXT with aromatase inhibitors or fulvestrant. And basically they showed that it's safe and that the response rate is the same that you would expect with TDXT alone. So right now we tend not to combine it, not to combine TDXT with endocrine treatment, but I think the idea of maintenance with endocrine treatment is not crazy, especially if the patient responded very well. So I think I consider it an option for a patient that went in an amazing remission with TDXT and is not tolerating TDXT. If you have to do a maintenance, instead of chemotherapy, using endocrine treatment is not crazy. But for the moment, I never combine TDXT with fulvestrant, aromatase inhibitor, or anything like that. We need more data to do that.
Great. My last question to you is that give us some insight on the emerging data on HER2 zero. Why would it work even though there is emerging data on that? My question is, why should it work, and what is the mechanism and what is the data emerging there? Of deruxtecan working in IHC 0. And the second question is the newer ADC anti-HER2 ADCs beyond deruxtecan. What is the landscape and which are the most promising ones? Please give us some insight into the future to follow.
So in HER2 zero, why should TDXT work? Actually, there's several answers. First of all, because zero is not really zero. HER2 zero, you still have some minimal expression of HER2. And if you use a more sensitive assay, actually you find thousands of HER2 receptors in what we call HER2 zero, because immunohistochemistry is not so sensitive. And this is one reason. A second reason is that TDXT, just like most of the ADCs, is not extremely stable. And so a lot of the chemotherapy that is bound to the antibody gets released when the agent is still in the circulation and can behave and can act just like normal chemotherapy. You have both effects. You have a targeted effect and a standard chemotherapy effect. And so some of that allows to work even when you don't have the ADC reaching the tumor cell, because the DXT releases in the circulation and reaches the tumor, the brain metastases, and everything else. So it can work, but based on the data we have seen from DAISY and from Dana-Farber, we saw that usually responses are short-lived. The PFS is around 3 to 4 months. And so probably for HER2 zero, we may need something else. The most promising for the moment, apart from sacituzumab govitecan, is datopotamab deruxtecan. And we have good data in hormone receptor positive disease, potentially soon in triple negative disease. What else? There is many more. One thing that is being attempted is to use the ADCs that worked in other cancers in breast cancer, such as enfortumab vedotin, works amazingly in urothelial cancer. It's been tried, tested in breast cancer, and maybe it's going to be promising. And then there is right now at least 100 ADCs in testing, most of them with topoisomerase inhibitors, but many other payloads. So if I knew which one is going to be the most effective one, I would become very rich. But in truth, I don't know, just because there are so many. And what I hope is that many of them show promising activity and many of them make our life easier, and we can choose and pick and choose depending on which one seems more active and more tolerated. But I think it's going to require still some time because most of them are in phase 1 testing. So for the moment, sacituzumab, TDXT, and Dato-DXT, the datopotamab deruxtecan soon will help us treat in our patients.
Great insight, Professor Tarantino. We learned a lot. I learned a lot when we all learned a lot from you and all our eminent panelists. And I personally thanks for this wonderful opportunity. I hand it over back to my dear friend and Dr. Chirag. Please take over, Chirag.
Thank you very much, Raja. It was a wonderful discussion and you covered a lot of points. And thanks, Dr. Tarantino, again for wonderful insights during your talk as well as in the question answer as well as in the panel. So we learned a lot of things in this evening and this morning with Dr. Tarantino. The important thing that we learned was that there are a number of ADCs which are going to take over the landscape in HER2 positive as well as overall breast cancer treatment. So that's one thing. Second thing is that the traditional learning that we had as per the series of ABC guidelines was that we should biopsy at least once during the metastatic course of the disease. What we have learned is that we should keep biopsying at every progression if possible, and that is going to give us a lot of insights. When we biopsy, or if we can't biopsy, a ctDNA also is going to give you a lot of information about how to treat that particular patient. It's just not limited to ER, PR, or HER2 or ESR1 or PIK3CA. It's a way beyond that information. So the things are interesting. The last decade has been interesting, and the coming decade is going to be even more interesting for oncology as a whole, for breast cancer in particular, and even further in particular for HER2 positive breast cancer. So thank you very much. Thanks to everyone, and back to the organizers for closing the session.
Thank you so
Thank you
much,
so much,
everyone.
everybody, for attending.
So much, everyone, to join today's webinar. Thank you so much. So we can close the meeting, sir?
Yeah, sure.
Thank you, sir. Goodbye. Good night.
Have a wonderful day. Bye. Good night.
Professor Tarantino.
Thank you.